Purva, shall I start?
Yes, sir, we can start.
Okay, thank you. Good morning to everyone. Good evening to everyone. I think, as usual, I start with the short case first. Is my slide seen?
Yes, sir.
Yeah, right. I'll start with the first case. This is a story of a 60-year-old man. History of acute onset of diplopia and imbalance while walking for the last 2 days. History of tilting of the body to the right while standing and walking. Known hypertensive. This is a short case only. This is a video of the patient. Look very carefully. Looking to the left side. Looking to the right. Looking up. Looking down. Lower canals are normal. Parallel movement normal. Motor power normal. But he's got fingernose incoordination of both upper limbs.
It's got incoordination, the right side.
Lower limb tone power normal. He has got Hilton incoordination of both the lower limb.
എല്ലിന്റെ പുറത്തോട് വരണം. ഇനി മുട്ടിച്ചിട്ട് ഒന്നല്ല ചെയ്തേ. ഇനി ഇവിടെ കൊണ്ടുവന്നേ. ഇതുപോലെ
The reflexes were normally elicited. Plantar flexor. Sensory system is also within normal limits. No difference anywhere in the body.
vibration.
Joint sense vibration, everything normal. His tandem walking is defective and tends to fall to the right side while standing. He will go to the right side like that. Apart from the tandem walking difficulty, while standing also he goes towards the right side like this, falls to the right side. So let's see the findings now. He has got a non-correctable ptosis of the left eye. In the left eye, there is adduction and elevation failure, partially restricted. There is mild abduction restriction of the right eye, bilateral limb and gait ataxia, and patient tends to deviate to the right while walking and standing. So these are the findings. If you want clarification of any findings, I will show the video once again. I'll be showing the static pictures later on.
Sir, what about the facial sensations, the tests of hearing?
Everything, the other kinds are all normal. Because it's a short case, I cut off the other normal findings. All kinds normal, sensations normal, corneal reflex normal.
So pupils also normal?
Pardon?
So pupils.
Pupils normal.
Sir, from the history and the...
Yeah, please. Yeah, please ask. Yeah.
Accommodation, sir.
Accommodation, I did not check. Because I thought there is a left third now, because got elevation is also restricted, there's a ptosis, and then the pupil is reacting to light.
Sir, from the history and the examination, it seems that the patient is having the left-sided third nerve involving the superior rectus, the medial rectus, and the LPS. And in the right side, there is some suggestion of sixth nerve involvement. Sir, and with that, there is ataxia, which is in all the four limbs, as there is also some body lateropulsion towards the right side while walking. So, a disease concerning the pons with the connection to the cerebellum along the peduncles should be thought of. I could not make out any nystagmus in this patient. So,
No
brainstem.
nystagmus.
So, a
No
brainstem with
nystagmus.
cerebellar connection at the level of the pontomesencephalic junction, a probable acute pathology should be thought of, sir.
He has got a definite third nerve involvement, no? The lesion has to be in the
Yes, sir.
mesencephalon variably.
Yes, sir.
So you want to
Pontomesencephalon. Yes, sir.
postulate both. Ponto means sixth nerve is much lower down in the pons. It is not in the pontomesencephalic junction. There has to be pons and membrane, correct?
Yes, sir.
Okay.
But sir, there is the ptosis is unilateral
Right.
and the pupil reaction is not seen. So we have to check with the pupil. So if there is pupillary involvement,
No pupil involvement.
so nuclear third nerve is a little less likely because it is a strictly
I'm not
unilateral.
telling nuclear third. No, it can be the fascicle. No, it may be in the
Yeah.
outside the
Yes, sir.
nuclear. Yeah, it may be
Yes,
anywhere
sir.
in the
But
fascicle.
it's
Sir,
prominent ataxia also, sir.
Yeah,
Prominent
correct.
ataxia.
Right.
sir, looks like
Yeah.
it's at the decussation of the superior cerebellar peduncle.
Okay, very good. That can explain the bilateral ataxia, correct?
And he has probably a fascicular third nerve also because
On the
fascicular
left
third nerve.
side.
And,
Correct.
the sixth, the abduction recession could be part of a, this Herring's dual innervation. This because of the adduction lag. Probably
Yeah.
that contribute to the restricted abduction on the right side.
No, that cannot cause abductor restriction. See, it's got a middle rectus weakness on the left side. That will not cause abductor. If at all it is, first it should be overacting.
Yeah. Okay.
Yeah, because of that excess innervation is going to the left middle rectus. The contralateral right lateral rectus, which happens to be the yoke muscle, should be overacting.
Correct.
But it is restricted. Yeah.
That cannot be explained, sir. Otherwise, okay, sir.
Yeah, agreed. Right. So any other person would like to make a comment?
Sir, was saccadic lateropulsion tested in this patient, the saccadic pulsion? Because there is some body lateropulsion also. So if we have to choose between the pons or the pons downwards, we have to look at the saccadic pulsion as well.
Right. The problem with the pulsion is they've already got a weakness of extraocular muscle. All
Yes, sir,
this
that is
nuclear, they'll be defective. So you cannot rely on that thing. You understood? So it's got a restricted movement of the abduction and adduction. In that case,
yes, sir.
lateral pulsion, yeah, we cannot comment on lateral pulsion. Okay. So any other comments from anyone? Okay. Now I'm showing the findings once again. Showing the failure of adduction failure on the left eye. Showing the elevation failure of the left eye. So left eye is moving less compared to the right side. And you can again see the abduction failure of the right eye on looking to the right side. Right eye is not going to the extreme of the eye. Clear. If at all, if we expect no overaction, but that is not there. Definitely there is a abduction failure of the right eye. Now, how to explain the abduction failure? You have to postulate a lesion in the pons. Can you explain everything by a midbrain lesion?
Pseudo
The
pseudo abducens on the right side.
Pseudo-abduction is due to the convergent spasm, which is producing that thing. But that's not there. It's actually subduction failure, not moving at all, even with the.
inhibitional palsy, sir.
Pardon? Not inhibition
Inhibitional
palsy.
pulse.
In hip palsy means suppose middle rectus paralysis, opposite middle rectus paralysis. Yeah. That will produce only the inhibitional paralysis. Okay. MLF behaves the same thing only, but how can produce
Yeah,
abduction
we
on
have
the
to check
opposite?
the duction.
Duction also will be affected. No, it's got a paralysis there. You're thinking of a third nerve paralysis. Duction will be invariably affected. You can't think that maybe the superior rectus due to nerve involvement and the adduction failure due to some other supranuclear connection. It's not put together. I thought it is a simple case. I don't know. Is it scientific?
Case files, sir.
Yes, that's the answer I want. So what are the, see, the frontomesencephaly pathway is coming from above downward. Okay, it causes only at the upper part of the body's opposite side. If that pathway is affected, you get a contralateral gaze palsy. If there is a left midbrain lesion, the pathway comes from the left frontal eye field, comes down the internal capsule through the midbrain on the left side, crosser with the left side, then cross to the upper part of the pond, cross to the opposite, cross to the right side. So left side midbrain lesion, just like a frontal lesion, can produce a contralateral gaze palsy. So to prove that point, what other test will you like to do?
You are.
Oculocephalic reaction.
Oculocephalic.
Right, very good. So let's see the oculocephalic reflex. The eye is right fully abduct. See, this eye is coming to the extreme on oculocephalic. See that one. The abduction failure is corrected. So that shows that the lesion is not in the abducen nucleus. It may be above the abducen, either in the PPRF or in the frontomesencephalic pathway. Oculocephalic means the abduction failure of the right eye is due to right gaze palsy. Now, so that's probably settled. So you can explain everything by a left midbrain lesion. And how to explain bilateral limb ataxia?
So, double decussation and crossing at the level of the SCP and MC. Yes.
Right. Total superior sublapid angle. It can be affecting the, if the crossing is, this is not the one, sorry. I copied one the idea somewhere that I did not fail to save that picture. I don't know what happened. Anyway, there's a crossing is there that if that is affected, you get affection of the bilateral cerebellar ataxia. What this picture is upper part before, after crossing. Before crossing, it can be affected again, produce bilateral ataxia. Now, how to explain the lateral pulsion to the right side?
Sir, it can be explained by two mechanisms. If there has to be a lesion in the pons or below in the right side or the midbrain or above on the left side. So we have the ascending graviceptive pathway will cross at the level of the medulla and reach the thalamus and finally the sensory cortex. So the lesion has to be in a place where there should be ipsipulsion or contrapulsion. Below the pontomedullary junction, it is ipsipulsion, and above it, it is contrapulsion.
Perfect.
The left contrapulsion, sir.
This is actually contrapulsion.
Yes, left contrapulsion.
Yeah, absolutely correct. What you want to say is correct. So this is to the graviceptive pathway this I have shown before. This is the pathway. I'll explain it later on. Now, you want to see the MRI in the brain? This is the MRI in the brain. There is no lesion in the pons. You can clearly see the lesion, the paramedian midbrain. I think then this is the lesion there. That is infarct in the paramedian midbrain lesion. So a midbrain lesion on one side, slightly going to the opposite side in the midline, it cut off the bilateral crossing fibers, can produce this thing. Okay, right. So that is about. Now, what is a pathological pulsion? The anatomical substrate most likely responsible for the sudden falling is the lesion ascending graviceptive pathway, resulting in imbalance in the roll plane. Roll plane is, this plane is called the roll plane. Your plane is forward and backward. So this is your plane is this one. The graviceptive input from the optic convergence with that from the vertical semicircular canals at the level of the vestibular nuclei to subserve the graviceptive pathway, also the pathway. These signals are passed on to the oculomotor nuclei and the cortical centers for the perception of verticality in relation to gravity. The direction of subjective visual vertical tilt corresponded with the direction of the body lateral pulsion, consistent with the lesion ascending graviceptive pathway. So this is the pathway. You can see the lesion is, as Ami was correctly telling, this is from the superior subserian canal and the otolith organ. They go to the superior vestibular nuclei, cross to the opposite side, and ascend in the MLF to the INC, where it is connected to the extraocular nuclei, to the thalamus, to the cortex. Lesion anywhere in the pathway can produce lateral pulsion. If it is before crossing the ipsilateral medulla or in the vestibular nuclei, it produces ipsipulsion. After crossing, it produces a contrapulsion. This is what is shown in the picture on the right side. So this is the pontine at the opposite side. Now, in the ipsimedullary lesion, the subjective visual vertical is before crossing. There are other explanations for the lateral pulsion. Lesions in the descending lateral vestibulospinal tract. This is for explaining only lateral pulsion without any limb ataxia. May it produce ipsilateral axial lateral pulsion as a consequence of impaired vestibulospinal postural control. Lesions in the ascending dorsal spinocerebellar tract, the posterior spinocerebellar tract, also induce ipsilateral axial lateral pulsion, but it also produces ataxia, impaired and absent proprioceptive information. Body lateral pulsion without limb ataxia was probably due to impairment in vestibulospinal postural control caused by lesion in the descending lateral vestibulospinal tract. The body lateral pulsion is associated with limb ataxia. It is attributed to the posterior or ascending dorsal spinocerebellar tract. The lateral vestibulospinal, how does it produce the postural maintenance? To play an important role in the maintenance of posture by exerting strong excitatory influences on the extensor muscles to keep the body straight and inhibitory influences on the flexor muscles. Thus, interruption of this lateral vestibulospinal tract decreases the extensor muscle tone of the trunk and lower limb on the side of the lesion, which is likely to cause the ipsilateral axial lateral pulsion. The axial lateral pulsion without limb attacks lateral pulsion to the lesion lateral pulsion. Okay, I'll do 1 or 2, 3 examples. Which are sorry. So that much about that case. Some or other, I did not save 2, 3 pictures. I saved. I did not. It is not seen anyway. Okay, any questions before I go to the proper case? Okay. Shall I go to the next case?
Yes.
Okay. I think before this case, I think I go to the before. I wanted to say it was not saved. That is the problem. I'll go to the main case. I'll show this case first before I'll come back to that thing. Okay, can you see this case? See my slide now?
Yes.
Okay. This is a story of a 44-year-old man. In fact, this case I wanted to discuss last time in the session of percent pitfalls in NCS. So that will come here also. In fact, this is given by Dr. Joy. The symptoms started 2 months back when he got up from sleep after a tiring day. When he got up, he had diffuse pain in the right upper limb, as well as numbness of the whole upper limb. He had pain in the back of the right shoulder at the onset. Along with this pain, he noticed inability to lift his right wrist and fingers. 2 weeks later, he noticed hollowing on the dorsal aspect of the right hand. So symptoms started 2 months back when he got up from the sleep. He had diffuse pain in the whole of the right upper limb, as well as that is what he said, numbness of the whole right upper limb. And he also complained of pain on the back of the right shoulder at the onset. Along with this pain, he noticed inability to lift his right wrist and fingers. 2 weeks later, he noticed hollowing on the dorsal aspect of the right hand. And he also noticed a groove adjacent to the thenar reminiscent. That video picture I will show. This is the video sent by Dr. Joy. He could not elevate his wrist and the fingers, but he can flex his fingers very well. And he noticed hollowing on that area. Then check the grip was normal, but he could not lift up his wrist Fingers are also weak, extensively weak. He could not lift up the fingers from the table. Then the finger abductors and adductors are also weak and easily overcome. The palmar index is also weak. However, the abductor pollicis longus and brevis is normal. The finger flexors are also normal. Wrist flexion was also normal. You see his noticing grew on the right side. That area showed there is unusually depression. That area has come up recently. So these are the findings in this patient. So I'll summarize. There was wasting of the interosseae, especially in the first dorsal interosseae. Weakness of wrist extensors, finger extensors, and interosseae. Normal power of the wrist flexors, finger flexors, and flexor pollicis longus. Sensory dulling in the distribution of the right radial nerve, which is not seen here. The dorsal, he was pointing to that area and sensory dulling. So this is the findings. Now, you want any clarification of the finding?
So the lumbrical power was checked separately, lumbricals?
No, separately it must not have checked. It's whatever video they showed, there's lumbricals we do not know, but the interosseae very weak.
Yes.
What were the Frohman signs, sir?
Again, I do not know, but these are the only findings which Joy had given me.
Sir,
The
proximal muscles are
sensory
normal.
was normal.
Sensations were normal, except for that the dorsal aspect of the hand, in the area of distribution of radial nerve.
Proximal muscles, sir.
Pardon?
Proximal muscles.
All proximal muscles are normal, thenar muscles are normal.
Sensory over axillary nerve area is also normal, sir.
Normal. The only area is
But,
that, yeah.
so there was no Horner syndrome?
No Horner syndrome, no failure pulse, nothing.
So from the history and the examination, it begins very hyperacutely with pain, and the weakness develops over a few weeks' time. So possible multiple mononeuropathy or a plexopathy can be possible, sir, because there is also associated with frank element motor findings with wasting. The weakness is in the distribution of the C7, C8, and also in the nerve pattern. It is in the mainly in the ulnar and the radial nerve distribution, sir. So, sir, a plexopathy with a neuralgic amyotrophy of the C7, C8 or the radial ulnar nerve distribution with mainly motor with some suggestion of sensory. So that is
Okay.
possible.
Yeah, that's very good discussion. But we should not bring it out C7, C8 radiculopathy. That term we should ideally should be avoided. Because once you say multiple nerve and plexopathy, that is acceptable. If you say radiculopathy, the muscle distribution, weakness distribution should have been the root distribution. It is not a C7, C8 radiculopathy. What is, I'll come to that. Okay, anyone else would like to make a comment?
Looks like this.
Patchy involvement.
Pardon? Yeah, Umar, please go ahead. Someone else is speaking, is interrupting.
Sir, looks like there is a proximal radial involvement, but there is only minimal sensory. The brunt of the attack is in the posterior interosseous now.
Yeah, but sensory is there, no, in the radial nerve distribution.
No, there's a proximal involvement only.
Okay, right. Okay, I understood. Proximal involvement with predominant effect in the distribution of posterior interosseous nerve. That is what he said. Okay, correct.
And
along with involvement in the ulnar also.
yeah, along with the
That's
ulnar. Ulnar is also in the distal because the flexor carpi ulnar is normal. And
Okay.
it's only the distal, probably probably this is a proximal only, but the involvement is in the motor part of the ulnar nerve.
Yeah. So we can explain it. Yeah, all right. This is
Patchy involvement, sir, involving posterior cord and medial cord, sir.
okay. Any patch involvement can explain everything, but ideally, if you can have distribution like that, the first diagnosis should be in the distribution of a radial and ulnar. That should be the localization. because it's a mononeurous multiple. It could be in the plexus. That's a different issue. But because there is no other thing to no other. See, if the distribution is corresponding to a nerve or to a nerve, think of that possibility first rather than thinking of a plexopathy. For example, it's multifocal motor neuropathy you take. If you only the distributed multiple nerves, that we should not think of a plexopathy. Okay. If some proximal muscle also affected, okay, you can think of plexopathy. I do not say it cannot explain by plexopathy, but first possibility should be multiple. Okay, let us see. Now, first question, is it radial and ulnar palsy? Yes, it's possible. Is it a radial nerve palsy only?
No.
Okay.
Interocular.
Yeah, it is possible. I'll tell you later on. Is it C78 radiculopathy?
No.
No, sir.
Why not?
Triceps
Because
has got good
because
power.
the FCR and the external carpal radialis and ulnar is normal.
Yeah, because the C8, C7, C8 mean the wrist flexes, finger pressure should be normal. Secondly, the sensory loss is in the dorsal aspect of that area, that correspond to the C6 root, not C7 root. Okay, so that area is also against. So it can explain the C7 C8 radiculopathy can explain the weakness of the finger extensions as well as small muscles on the right hand. But what is against sparing of the wrist and finger flexes, which are separated by the same roots. Sensory dulling of the dorsal aspect of the wrist, that is the C6 diameter. So it's not so one thing we can reasonably exclude is the C8, C7 radiculopathy. Now, again, another point is the right triceps is normal. Somebody's already said reflex is also normal. Now, why not radial nerve alone? Obviously, you all know the answer. The interossei can be affected. Next question. Is the apparent weakness interossei due to finger drop?
Yes, sir, possible.
Yeah, in a finger,
Weakness can occur, but
But the
wasting how can...
wasting and the
Yes.
FDA, sir.
Right. Right, that's the point. You can have an apparent weakness of the interossei due to wrist drop. That cannot, it's a very mechanically disordered position for the interossei to produce its function when the fingers are dropped. So you cannot get an apparent weakness in interossei when there is finger drop. Why? Because the action of the interossei is flexion of the metacarpophalangeal joint and extension of the interphalangeal joints apart from his finger abduction adduction action. When there is a finger drop, the metacarpophalangeal joint is flexed, the interossei are therefore relaxed, and it cannot produce its full action. That is why it produces an apparent weakness. That is why you have to passively, when you want to check your interossei, just like what Joe has done, put it on the table, and then check the interossei, abduction, adduction of the fingers. That is, we have to passively extend the metacarpophalangeal joints for the interossei to produce its full action. As seen in the video, when you test the interossei, you have to keep the hand on the table before you check the abduction adduction. Okay. No, the next question is already answered. Is an apparent weakness in interossei? No, the patient is wasting in the FDA, which you cannot get an apparent weakness. Moreover, there is also some adductor wasting, as shown by the fact that you say some groove has appeared behind beneath the thenar eminence. That usually occurs with the subjacent is adductor muscle weakness. So adductor, ulnar paralysis, adductor paralysis can produce some groove below the thenar muscle, thenar eminence. Now, next question. Can it be aberrant communicates the radial nerve supplying the interossei? This is called the Froment-Robber nerve. That is, but I'll show the nerve. It's this anastomosis, just like our Martin Ruber anastomosis. It's a rarely described anomalous branch, either of the posterior interossei nerve or the suprascleral radial nerve that provides innervation to the intrinsic hyoid muscles, typically the first dorsal interosseous, but other muscles may also receive innervation from this anomaly. That's called Froment-Robber anastomosis. The distal motor fibers innervate the FTI as well as the second and third interossei but they may also innervate the adductor pollicis. The lateral part of the muscle intrusion, they will supplying by the posterior intrusus nerve. So this is a picture of this anastomosis. You see the posterior intrusus nerve, which is supplying, which usually does not have a supply in the hand at all, but it supplies the posterior intrusion. Now, next question. Can our patient be having this anastomosis where the radial nerve can supply the intrusion as well as adductor pollicis?
Yes.
Yes, that's possible. Okay. If it is that, we can explain everything by a pressure pulse. Okay. Radial nerve pressure pulse, why intrusion affected? Because that's also got
Yes.
compressed. Okay. Now, so what do you want to do now to differentiate all these things?
Yes.
NCD. So that as to before, this case mainly for teaching the person before NCS studies. So let's see the NCS in this patient. So what do you like to do in this patient? In every NCS study, you have to plan depending upon what you got in the examination. That is, in the first lecture I told that it is an extension of the clinical neurology, ADS examination. So you have to find here the problem is radial nerves, is it supplying the introshi or not, that FT or not? That is a question. Okay. Right, I will show the NC independent. This is the MNC findings. This is the right median, APB normal, left median normal. Right ulnar ADM supply decreased compared to the left ulnar ADM. Right is the affected area. Obviously, the amplitude is less compared to the other side. Okay, so ulnar supply to the ADM is decreased. Now let us see the radial supply. Again, radial supply to the EIP is also decreased on the right side. So obviously, right radial is affected, right knee ulnar is also affected. Left radial EIP is normal, that's normal side. So right radial CMAP is vastly decreased. Right ulnar CMAP from the ADM is reduced compared to the left, but less than 50%. So then can we rule out trauma and rupert anastomosis here?
So we have to check the impulse from the ADM while we stimulate the radial nerve and see whether there is any
No.
impulse on CMAP.
Not the ADM, the FDI.
FDI, sorry, FDI. Yes, sir.
Okay. So let us see. So what will you do to know the FDI was really supplied by the radial nerve? What you said is correct. That's why I said you have to plan investigation according to what you, not the routine NCS study. So how to know that radial nerve is supplying the introtia and not the ulnar? You have to put the pickup electrode on the FDI and stimulate the ulnar as well as radial. Okay. Right. If FDI is supplied with radial nerve, the amplitude picked up from the FTA on ulnar stimulation will be low because it's partly supplied by the radial compared to the left side, and you should be able to get potential from the FTA on radial nerve stimulation. Correct?
Yes.
Yes, sir.
Okay, because we suppose in the radial nerve supplying the FTA, part of the supply only from the radial, part may be from the ulnar, may not be entirely from the ulnar. Okay. If no potential is picked up from the radial in FD also, it's okay. But radial stimulation should pick up potential from the FDI. The ulnar may pick up, may or may not pick up, but may not be taught. Yeah, please. Yeah, please ask. Yeah. Is it clear to you?
Yes, sir.
Okay. Now let us see what's happened to the patient. Presume he had a foramen robber anastomosis on the right side. So let us see the FDA pickup from the ulnar stimulation first. So I'm doing pickup from also from the radial. From the ulnar, this is 4.3 only. Okay, that is amplitude is low. Left is normal. So left ulnar stimulation FD is normal. The right side, the FDA pickup is decreased. So it may be partly ulnar nerve is affected, or part of the supply is not from the ulnar, but maybe from the radial nerve. So CMA from the FDA from the ulnar stimulation is slow compared to the left side. That is a conclusion. It means that it can be an ulnar nerve paralysis, or the supply of the FDA is partially from the radial nerve, partially from the ulnar nerve. Correct?
Yes, sir.
Yes, sir.
Yeah. Okay. So if you got any doubt, clarification, please stop in between, ask, clarify, and go. Okay. So let us see what happens if you stimulate the radial nerve and pick up from the FDA. That's the next thing. Okay. Now this is FDA pickup from the radial. Radial is not supplying the FDA. But if an anastomosis, it should be supplying. So FDA pickup electrode is put on the put on radial nerve stimulated. This is the right radial stimulation is 1.2. Left radial stimulation is 2.6. So what does it mean?
Then there must be an anastomosis because the left radial is also supplying the FDI then.
Correct. So that means that the patient's got a bilateral
Prometro.
bilateral anastomosis. Otherwise, should FD be picked up from the left radial? Why the right radial FD pickup is low? Because that is partially compressed. That is affected. So naturally, the amplitude will be low.
Can we see the waveforms, sir? Those images are there.
Because what you said is correct. This is all not my case. This is all sent by my Dr. Joy. The waveform only values are there. Waveform is not a value.
Can it be due to
Sir,
volume
even
conduction, sir?
We'll get volume conduction by the let's see how volume conduction how we are stimulating the radial only, no?
Sir, you only told we should see the waveform, not look at the
Right.
values.
Correct. That's agreed. Perfectly agreed. Let us, without that, let's analyze the situation. I'll come to the volume conduction later on. Okay. Okay. Right?
So how much should be the velocity, sir, in the left radial nerve? Like this, that 5.73, it should be 2 something, that's a 2.5 something.
No. Here,
And
no, there should not be any potential from the FDI if the
okay.
the radial is stimulated. Because that does not come below the wrist at all.
Yes, sir. Oh, okay, sir. Okay.
Okay. So any potential obtained means there is a communication.
Yes, sir.
Okay. Okay. Let us see. That means that there is anastomosis bilaterally. And in addition, there is a radial nerve affection on the right side in view of the low amplitude from the right side compared to the left. Correct?
Yes, sir.
Okay.
Yes, sir.
Now good. No. So we think that patient's got a anastomosis. You all agree with that, no?
Yes, sir.
Okay. Now let us see the pickup from the FTA once again by the stimulation of both the nerves. Now I'm showing both ulnar and radial. Okay. This is ulnar stimulation FTA pickup as shown before. That is low. Obviously partly supplied by the ulnar, partly supplied by the radial. Left ulnar FTA is normal. Radial stimulation pickup as shown before. Right, both are picked up from the FDA. Okay. This is the two things I already said. What is the conclusion? That means the patient's bilateral anastomosis and the FT is separated by the radial nerve on both sides, correct? Which we thought.
Yes,
Right.
sir.
Okay. Now, presence of radial nerve compression on the right side will result in decreased EMF amplitude on the right EAP as well as FD on the right side as in our case. That's also understandable.
Yes.
Agreed? Okay.
Yes, sir.
So it's a foment prober anastomosis in our patient.
Most
Agreed?
likely.
Most likely. Why most likely? I know definitely. Anyway, in
Yes, sir.
neurology, it should be like that. Most likely only. We can't be definite about anything in neurology. Okay, now this is what you said is correct. This is unlikely. Why? Now, listen to me very carefully. If the patient happens to have bilateral anastomosis, the left FDI, okay, the left one, supplied by the radial, left FDI amplitude stimulates ulnar nerve should also be reduced since the patient's got bilateral anastomosis. Got the point?
Yes,
But
See,
sir, the FDI may have dual supply by the ulnar and the radial nerve also, sir.
correct. So that means that what dual supply means what? The FDA stimulation on ulnar also should be decreased because FDA is supplied with radial also.
Yeah. But sir, in the right side, it is also decreased, sir. The right-sided ulnar CMAP and the radial CMAP on the FDI both are decreased. So
Correct.
probably there is an FDI dual supply by the ulnar and the radial on the right
Okay.
side.
Right. That part I agreed. Then my question is, if there is a bilateral anastomosis, what do you expect? What do you expect? The amplitude on ulnar stimulation, the FD should be less, apart
Yes, sir.
from the potentially picked up. But here it is normal. I'll show the
Normal,
value.
yes.
Yeah.
13. Yes,
And
13.
this is not a reduction of patients. I think that there is no anastomosis on the left side. See the value now. See the ulnar FDA is normal. Okay. Now the question comes, then why you should pick up a potential from the FDA on radial nerve stimulation? Again, the question comes.
Volume conduction.
Right. Volume and that come to that later on. That means that the decreased CMAP amplitude on the right FTI on ulnar stimulation can be either due to right ulnar nerve affection or anastomosis on the right side alone, not on the left side. Then why are we getting FDA potentially on both sides of radial stimulation? That's a question you have to ask yourself. And let us how to explain the CMAP potential from FDI. This is the value. You see the CMAP amplitude, you wanted to see the picture. That is the one. Now, how to explain the CMAP potential from FTA on radial stimulation? Is it due to the volume conduction produced in the inadvertent stimulation of the adjacent ulnar nerves as well when the radial nerve stimulated? Can be volume conduction. That means when you stimulate the radial, ulnar also getting stimulated. But that what you get is maybe only that one. It can be that volume conduction. That's what he said, no?
Possible, sir.
You understood or not? Volume
Yes, sir.
conduction is
Possible, sir.
it's possible. So that's a very well explanation which can explain that thing. Because you are stimulating the radial, but actually what is happening along with the radial, you are also stimulating the ulnar nerve. Because you are stimulating too high, giving the input too high. So that is unlikely. Because the site of ulnar is quite far from the radial nerve. Let us see this one. See, this is the radial and this is the ulnar, far away. So it's very unlikely that ulnar is getting stimulated by your radial stimulation. So volume conduction is less likely explanation. What to do now?
Can we stimulate closer to the FDI, sir? I mean, is it possible to give a stimulation
Yeah, correct.
after the tentative?
Yeah, that is possible. But the problem with the radial nerve stimulation is that after that area, they're all deeply situated to stimulate the radial. It would difficult to stimulate the posterior interosseous nerve per se.
No, I was asking ulnar stimulation, sir. Is it
Ah.
possible to do it close? Ulnar stimulation, is it possible to do it closer to the FDI? Like after the anastomosis joins and before the anastomosis joins, so that we can show an increase in the amplitude.
Okay, that is, if it is possible, it is okay. But that I don't, it will be difficult in that case because ulnar nerve comes here and supplies hypothenar and then it does not go that direction. With anastomosis, it may be able to stimulate. I do not know about that, whether the anastomosis is present or if only ulnar is supplying let's go to the deeper branch, no? That's a deeper branch. We can only stimulate the proximally here, in the near the pisiform bone. Once it enters the Guyon's
Sir,
canal, it is deeper.
No.
sir, in an anomalous connection, ulnar nerve can be near the radial nerve, no, sir? It is possible, no?
Ulnar nerve can be near the radial. No, what happens here is the posterior branch is supplying the interossei. Ulnar nerve is supplying normally only, FD and everything. But here the supply, the FTA is coming from the radial. So you have to stimulate the radial branch, posterior branch. That will be difficult in the distal part. And we do not know what is the where is the anastomosis exactly, we do not. Okay. Now what will you do to find it whether it's volume conduction or not?
So if you a proximal stimulation, I mean, at the radial groove and the FDA.
Again, the same only. Wherever it stimulates, it is anastomosis, it will stimulate.
Is it
We
like
should
that,
go and
sir?
see in the
You mean to say that the radial groove to stimulate the radial to find out the pickup from there to
Yes,
avoid
sir.
volume conduction?
Yes,
Okay,
sir.
that's a sensible thing and say that. Okay, that's one can do. But
so we have to
most
go and see in the lab, sir.
correct. That's
Look at the
look
muscles
for-
which are contracting.
very good. That's the answer I want. Look at the muscles which is contracted. See, if it's radial nerve stimulated only, that radial muscle should contract. If some other supplied by the ulnar is contracting, that is entirely different. That shows the volume contraction. Let us see. So always look for which all muscles go into contraction with the nerve is stimulated. Let us see the video. So I asked Joy to send the video stimulation showing the stimulation FTA when the radial nerve stimulated. Let us see it now. This is the radial nerve stimulation. Okay. Okay. What is your impression?
He's moving the hands, volume.
No. What is your conclusion after seeing this video? The problem, none of us go and see NCS being done. Correct? That's a bare truth I'm telling. We always rely on what the electrophysiology bring the values, look at the value and interpret. We never go and see what the electrophysiology is doing. They may be trainees, no? They may not know what they are getting. They could check potential. They just report the value, report the latency, and bring it to you, and you make a beautiful report out of that thing, and they ultimately get confused and make a wrong diagnosis.
Is it because there's a flexion of the inward movement of the hands, not extension.
Right.
Elbow flexion.
Right. That's answer. See, this is not a radial nerve conduction at all.
Yes.
Radial stimulation steady body is extension of the wrist, extension of the fingers. What you observe here? Flexion of the wrist, flexion of the fingers, and flexion of the thumb also. So what is happening here?
Ulnar nerve is getting stimulated, sir. Anastomosis is there.
No, not ulnar nerve is getting stimulated.
Median, sir.
Median, sir. Median is convection.
Median.
It is the median. If ulnar nerve is stimulated, it's going to produce flexion of only the medial two fingers. There should not be flexion of the thumb. Secondly, you get ulnar deviation of the hand and the wrist. Here is a flexion of the wrist is happening. So what is happening? When the radial nerve is stimulated, so-called radial nerve stimulated, what you expect is the extension of the fingers, the radial nerve is intact. Radial is affected, you may not get the extension of the fingers. If ulnar nerve is stimulated, you expect flexion of the middle two fingers, and ulnar deviation of the wrist, and abduction of the index finger. What is observed is the flexion of the wrist and fingers and flexor pollicis longus, suggesting that it's the median nerve which is stimulated and not the radial ulnar. So I'll show the video once again. See the flexion of the fingers and flexion of the thumb. Okay. So that means here is a median which is stimulated. So what all values which you have got as radial stimulation FT pickup are all because of the volume context. Now I'll tell you why the volume, then you may ask why that produce stimulation of the FT. I'll come to that later. So is how we can make mistakes now. See, this is radial stimulation, this is a median stimulation. So close. See, this is the elbow, this is the here and here. Now look at the anatomy here. Median and close together. But that ulnar is far away.
Yes, sir.
Suppose you put the electrode somewhere in the middle, okay, not laterally, middle, you're going to stimulate both. Then you may ask why potentially. Then you can guess why. The next question. Okay, there is a volume context. That means median is stimulated. Agreed. But why should you pick up the potential of the FTA then?
Then median.
You stimulate the median. No, you're picking up electron from the FTA.
Then there should be another anastomosis.
Anastomosis, sir.
Again, no. This
You're
again,
picking up from ADM, I mean ADB.
That's the answer. See, I'll tell you. See, where is this FDA situated? Between the thumb and this thing, no? Just between the web space below them. Just above, below, just ventral to that is your thenar muscle. Okay, if you stimulate and pick up from the abducted pollicis brevis or flexor pollicis brevis, just below that is the FDI. So you pick up from the ADA or abducted pollicis brevis, it will be misinterpreted as picking from the FDI.
FDI.
Okay, fine. So most likely supported with the thenar muscle, which lie close to the FDI. Now this is look at the anatomy here. This is the adductor pollicis. This is the first dorsal interosseous. I think, in fact, there is another picture which I drawn very clearly that is missing here. This is I can see the arrow here. That is the first dorsal interosseous. And this is the thenar muscle. See how close they are. This is one. This is the. Okay, I don't know. This is the one. This is the one. Okay, so it's very easy that you can easily pick up a potential from the so-called FTA, which is only conducted from the subjacent thenar muscle. So final interpretation, that means that the CMAP amplitude which we got from the FTA on the so-called radial stimulation was actually not from the FTA, but from the thenar muscles which lie close to the FTA and operate from the co-stimulation of the median nerve producing action button in the thenar muscles. This is actually right ulnar nerve affection per se to account for the decreased CMAP amplitude on the right FTA and the ulnar stimulation. Okay, so definitely there is ulnar plus radial in this patient, not anastomosis, not a radiculum. Now let us see the rest of the NC study. I showed only the motor conduction. The sensory snap also not totally, but mildly decreased on the right on the affected side, 44 compared to the 64. And look at the FAV is also slightly prolonged in the ulnar nerve on the right side compared to the left. So that means that the patient has got both right ulnar is affected, and points favoring ulnar affection over the anastomosis is that decreased CMAP amplitude from the ADM, which is not supplied usually by the anastomosis. Decreased ulnar snap. Anyway, anastomosis is there, you can explain the motor. How can I explain
The posterior interosseous is a pure motor nerve.
Pure motor nerve.
So in this case, there is a sensory. It's
also,
I mean,
even
the
it's totally
ulnar, the sensors of Plays through the post-interstitial nerve.
Right. And mild prolongation FA latency on the ulnar. So these are the points favoring that it is not an anastomosis, but an ulnar lesion. Now, what is the etiology now? Could be a pressure pulse of both the nerves. Very unlikely. How can pressure pulse occur both the nerves simultaneously? To get radial ulnar, to get affected at the same time. The both are liable for pressure palsy, but occur at the same time is very unusual. Not logical. Yeah. And he gave a shoulder pain in the onset. So most likely, as you thought, a typical form of neurologic hemiatrophy. So final diagnosis, right brachial hemiatrophy, not foment robber anastomosis. Now, any questions?
Sir, in this case,
during
if you do a MR, contrast MR, can we find out the lesions or the enhancement in the proximal part of the plexus?
Very often, this flexopathy will not be picked up by MR. Because nowadays I stopped doing it because many times it comes as negative. And even if you find mild enhancement or thickening and all, I said many normal individual we can find some asymmetrical thickening and all. I do not believe on thickening, but sometimes misleading. Because previously I was there thickening and thickening. Somebody, normal also find thickening, special for something else. So I gone many times I burned my finger. One case I think this I told you sometime back that a particular antibody, what antibody? The neurophilin antibody was positive because there was thickening on the plexus. Sent for the antibody. Antibody came as positive. Started giving IVIG, steroid, and I even took SMAP. Ultimately found the patient was having only functional problem. So, so always clinically stop. Clinical examination is the top thing. No other investigation can supersede an examination. These false positive antibodies, false positive thickening of the nerves, all can be problematic at times. So if it correlates with the clinical, go for that. Otherwise, no.
Sir, in this case, though the involvement is distal, can we still get a sensory impairment of the upper lateral arm? Sensory
No,
impairment.
that if you, sometimes what is said is correct. Sometimes I've seen that person with the distal involvement, sensory loss on that area also, because actually it's one of the favored nerve getting affected with the brachial plexopathy. But again, not all the time. Brachial plexopathy is a condition it can vary. Some can present only with phrenic nerve, only with rectal nerve. Some days rectal angina with some other nerve. It's very peculiar. I have shown you with extensor pollicis longus weakness alone. I have shown you flexor pollicis weakness alone, anti-intrusions. Now only that muscle is weak. So these are all a typical presentation of brachial neuritis.
Now, when the technician was stimulating the radial nerve on the left side, there was also some flexion at the level of the elbow. Was it due to the brachioradialis contractions?
Maybe direct stimulation, maybe some direct stimulation of the muscle.
Because that is not possible with median nerve stimulation, sir.
Yeah, and that's what I said. Direct stimulation of the muscle can also produce some stimulation.
Sir.
Sir, ideally, this nerve connection, we have to keep the hands in a supine position, no, sir?
Yeah, correct. Supine position.
So that we can know the position of the nerve.
Right. And best thing, whatever be the position, more important thing is that find out the muscle contraction, which are the muscles is contracting. Then you know you are in the correct nerve. If
Yes.
the muscle is contracted, then you are stimulating some other nerve.
So then this is not mononeuritis multiplex, sir, only brachial.
You are justified in telling mononeuritis multiplex. Absolutely correct. But I'm only, since the patient has shoulder pain and everything before, more likely a manifestation of brachial. That's all. Otherwise, it can, suppose there is no pain here, nothing there. It can well be a mononeuritis multiplex due to anything else. So, diagnosis mononeuritis multiplex. But since yet a presentation is like a brachial neuropathy manifesting as mononeuritis multiplex. So I told you before, somebody's only phrenic nerve palsy, only vocal cord palsy as brachial neuritis. It's actually nerve is affected only one nerve, but it's a part of brachial plexus. Then we should not call it brachial plexus, we can call it neuralgic hemiatrophy. Brachial plexopathy means that gives an impression that brachial plexus is affected.
Sir, we need not do MRI brachial plexus for this case.
No, not necessary. Deletion
And
was
it is not useful. It is not useful
not
in
useful.
brachial.
No, not useful.
Sir, what is the presentation if the phrenic nerve is affected?
What is the case?
Presentation, phrenic nerve.
They came with breathlessness.
Breathless.
In fact, he came with the shoulder pain and then developed phrenic nerve palsy. One diaphragm is not working. Luckily for me, he had some weakness in the deltoid also.
Okay.
Okay.
Otherwise, how to find out that diaphragmatic, that fluoroscopy?
Fluoroscopy.
He came
Okay.
with the breathlessness, really one diaphragm is, the chest is not moving, then abdomen is moving. Fluoroscopy showed diaphragmatic palsy.
Okay.
Okay, some few words of the course. Yeah, please.
Sir, if you if there is a diaphragmatic palsy, how will you treat it, sir? Sir, same it.
Steroid.
Same.
Okay,
I give
sir.
the patient.
Sir, we have to take it as a neurologic hemiatrophy, sir.
No, I tell you, if you got a diaphragmatic palsy, the first thing is to rule out all other causes. Okay, you have to investigate, you have to the chest X-ray, CT, chest X-ray, other cause of vocal cord palsy, thyroid disease, everything is come in the DD. Because if you got only focal lesion there, if you that focal structural pathology compressed the nerve is ruled out only, you can consider as a brachial neuralgic hemiatrophy. Otherwise, we should not.
Sir, I had two
Okay.
patients in the past. He had a classical patient is unable to lie down because they get
Right. Yeah, correct.
breathless and they sleep during the night and in a easy chair only. They're never able to lie down for, and they were in investigated for echo. Everything is done. The only symptoms that are unable to lie down.
Yeah. My patient also something like that only. He is walking out now. But that particular pain did not totally improve. He is now 3 years now. He still need a CPAP at night, but that breathlessness all disappeared. He was also not able to lie down there at night. That is his main complaint.
Sir, they will have seesaw breathing, phrenic nerve palsy.
Yes, you can have, but only if it is usually that find any bilateral involvement only you get a classical seesaw breathing. Unilateral diaphragmatic palsy by examination difficult to find out. Only thing is you have to do fluoroscopy.
Sir?
Yeah.
Sir, suppose if it's a traumatic brachial plexopathy, sir.
Yeah.
And NCS is showing CMAP amplitude reduction in the upper trunk, so like deltoid and suprascapular muscles, sir.
Correct.
Sensory is normal.
Yeah.
But should we need to do MRI, sir? Because MRI, they have plate and other things, sir. They told they couldn't do. How will you proceed, sir? Will you?
No. If you could suppose if the lesion is clinical findings suggest a plexus injury, if possible, try to do MRI also because someday there can be dual pathology. Dual pathology means that double crush syndrome. If you got a brachial plexopathy, you find SNAP will be absent. You may think that, oh, SNAP is absent. It's likely only pure plexopathy. He is going to improve with treatment, with physiotherapy and all. Suppose he has got an underlying root avulsion, that will be missed. Because so root avulsion, you can diagnose only a pure root avulsion, pure plexus, then the SNAP is going to help. If both are affected, you cannot rule out the underlying root avulsion. That is why the MRI is required. So in a brachial plexus injury, ideally MRI is required. Post-traumatic, as you're talking about, not the classical neurologic hemiatrophy. That situation, MRI should be done.
Sir, if we couldn't do what to do, sir, can we do CT or because they told MRI plate is there, they couldn't do like that, sir.
Yeah, in that case,
CT
error,
myelography.
CT myelography can be done.
Yes.
We can find the root dangling in that thing that will, but
Pseudomeningeal.
pseudomeningocele. Not only pseudomeningocele, you can also see the root is separated from the cord. A clean cord you will find. I'll show. Did I show one case like that before? No.
Yes, sir.
Okay.
Yes, sir. Yes, sir.
You have shown one case where they dangling roots. So that is a
Roads,
spinal cord.
Yes, sir. That's
right.
right.
Yeah. So, few words about the co-stimulation. This you should know. For NCA study, we are giving supramaximal stimulation to ensure that all nerve fibers are stimulated. One problem is that if the stimulation is too high, the stimulus current may spread to excite the neighboring nerves. As the neighboring nerves are stimulated spuriously, large amplitude potentials may result, caused by the co-recording of additional muscle or nerve potentials. Co-stimulation occurs commonly in motor studies of the upper limb, when the median and ulnar nerves are stimulated at the wrist, elbow, or in the axial nerve. In the lower limb, co-stimulation of peroneal tibial nerves more occur at the knee because they are close together. Now, remember these 2 points. Inadvertent co-stimulation of the adjacent nerves can create a host of problems. A low amplitude potential due to axon loss may reach the normal range if adjacent nerve is co-stimulated. For example, the first one is the correct potential, but if the adjacent nerve is also affected, what will you get? You get large potential. You may miss an axonopathy. Secondly, if the co-stimulation occurs distally, both nerves are stimulated distally, and not proximally, a conduction block may be erroneously diagnosed. What is this one? This is a normal potential. But if you find distal part has got a co-stimulation, both are not stimulated, not proximally, the distal amplitude will be larger, proximal will be lower. So what will diagnose? Conduction. That is erroneously diagnosed. On the contrary, the same token, if there is a true conduction block, co-stimulation at the proximal site will result in inappropriately high amplitude proximally, which may obscure a true conduction block. For example, this is a proximal stimulation showing a conduction block in the upper panel. If there is elbow co-stimulating, you get a large amplitude potentially may miss a conduction block. So what are the ways to avoid co-stimulation? Ensure that stimulus is directly placed on the nerve. The ideal thing what you should do is that, what you should do, but gradually increase the current milliamperes till the maximum amplitude is reached, then another 10% you give. When you increase the milliamperes, before you reach the maximum potential, move the stimulator side by side to find out the maximum amplitude with a lower stimulation. Then you know that's the correct position of the nerve. When the subaxial potential is got, you can move the stimulator parallel to the initial stimulated side, slightly medially and then laterally, while the stimulus current is held constant. So not the full stimulation. Then you can move the stimulating electrode so that you get a maximum. That's the ideal place. The position that yields the highest amplitude response is the position closest to the nerve. Once the optimal position is determined, then the current can be increased to supramaximum. That is one technique. Then watching the amplitude of the waveform increase. When increasing stimulus intensity, the shape of the waveform will often change abruptly when the co-stimulation occurs. So when you're stimulating the ulnar, median now, the pattern of the wave, it will be amplitude is increased. Suddenly you find that become different kind of a morphology. That means that you are stimulating some of that now. That usually occurs when the stimulus index is more than 50 ampere. And this already told you, often can be avoided if attention is paid to the evoked muscle twitch as happened in our patient. And other pitfalls, electrode positioning. the active electrode should be placed on the end plate zone on the motor point. Usually the motor point is the middle of the muscle. The reference electrode is usually placed to the active electrode. So this is the electrode position is not the motor point, you get a potential length. And usually you get a downward deflection or the positive deflection. If it is not in the correct placement, mean you get a negative deflection. That is upward deflection. This is the correct placement. If the electrode is exactly on the motor point, you get a negative potential initially. If it's not, otherwise you get a positive. Just like if it is away from that, you get an initial positive deflection. Again, sensory studies also, when the nerve is close to that, you get a higher amplitude. The stimulating electrodes moving away, you get this thing. Okay. Okay, this again, the distance between the active and reference electrons matters. G1, G2, when it's close together, less than 1 meter, you get a low amplitude. Distance between the active and the reference electrode is more, you get a larger amplitude. Okay, that's regarding that case. Okay, shall we stop here or go for one more case?
What was the treatment given, sir, for
One
this
short
patient?
case, sir.
That particular steroid was given, then patient improved. Shall we stop? Okay. Okay.
Thank you, sir.
Thank you. Good night.
Thank you, sir. Good night, sir.
Good night.
Good night, sir.
Good night, sir. Good night,
Good
sir.
night, sir.
Good night.
Yes, sir.